Welcome to the ACL TV. This video was created from a full-length article on our health website. I'll drop the link to the article in the description box. After watching, please ensure you subscribe, share, and like.
I want to start today by putting a number on the table. It's one of those stats that when you first see it, you just assume it's a typo.
I have a feeling I know which one you're talking about.
Mm-hmm.
Is it the population versus the disease burden?
That's the one. Let's just picture the map for a second. Africa holds about, what, 15% of the global population?
Well, roughly 1 in 7 people on Earth, yeah.
Right. But then you look at the global burden of communicable diseases, the sicknesses that spread, and we are carrying nearly 50% of that weight, half of it.
It's a staggering imbalance.
Mm-hmm.
And honestly, it's a painful one, because when you hear 50% of the disease burden, it's so easy for that to just become an abstract idea, you know.
Line in a report.
Exactly. But what it really means is families losing their breadwinners. It means children missing school. It's this constant low-level drain on the energy of our communities.
And that drain, it has a price tag, a massive one. The source material we're looking at today connects health to the wallet in a way I hadn't fully appreciated before.
Oh.
It says the region loses an estimated $2.4 trillion in annual output due to poor health.
2.4 trillion. I mean, let's just try to visualize that for a moment. That isn't just money lost on hospital bills.
Yeah.
That's money vanishing because a factory worker is down with malaria and the whole production line slows. It's a farmer who can't harvest because of a chronic condition that just wasn't managed. It's the potential of our economies literally evaporating.
Because the physical foundation, the human body, isn't being supported.
Precisely. An unhealthy population cannot be a productive one. It's that simple.
It seems so obvious, but we often treat health like this separate, almost charity bucket, totally distinct from economic growth.
And that's the fundamental mistake. Health isn't some byproduct of wealth, it is the engine of it. And if that engine is sputtering, our economy, it is going anywhere fast.
So today we're going to look under the hood of that car. We're not talking about specific diseases or some new wonder drug. We're talking about the machinery itself.
The invisible architecture.
Yes, that's a great way to put it. We're doing a deep dive into health system strengthening.
Which can sound a bit dry, I'll admit, system strengthening. It sounds like something from a Geneva conference hall.
Right.
But in reality, it is the most urgent conversation for our continent's sovereignty. It really is.
To guide us, we're unpacking a really fascinating article by Dr. Azuka Chinwoku Ezike from the DACE Medical Consulting Library. And it pulls in some sharp insights from Dr. Babatunde Sani.
And what's so important about this particular deep dive is the perspective.
How so?
Well, this isn't a lecture from the global north about what Africa should do. This is an internal look. It's us asking how we take ownership of our own survival.
That's the crucial shift, isn't it? For decades, the narrative has been about aid. It's been about what donors can give us.
Dr. Ezike and Dr. Sani are flipping that script. They're asking, how do we build a system that stands on its own 2 feet, regardless of who's in the White House or Downing Street?
So let's define this system, because when I hear health system, my brain just immediately goes to hospital. I see a building with a red cross on it, but that's way too narrow.
A hospital is just a building, a health system. That's everything that happens before, during, and after you step into that building.
Okay.
Think of it like this. The hospital is the stage, but the system is the script, the lighting, the logistics, the funding, the actor training, even the ticket sales.
I like that analogy.
If the logistics fail, meaning the supply truck breaks down, then the doctor on stage has no medicine. If the funding fails, the lights go out. A system is that entire web. And as we all saw very recently, that web can be incredibly fragile.
You were talking about the pandemic.
COVID-19 was the ultimate stress test. I mean, do you remember the atmosphere in early 2020?
Vividly. There was this just palpable anxiety everywhere.
But the anxiety wasn't just about the virus itself. It was a very specific fear, wasn't it? It was, how will our systems cope?
Yeah, we looked at Italy, at New York.
And we knew our own invisible architecture had cracks. We feared a total collapse.
And yet, here's the paradox that Dr. Sani points out, and I found this really surprising. He argues that African countries don't actually have a shortage of ideas.
That sounds contradictory, right?
It does. But he says, we've produced some of the most forward-thinking health policies in the world.
And it's true. Go to almost any Ministry of Health on the continent. You will find brilliant strategy documents. Vision 2030s, strategic roadmaps. We are excellent at the what. The problem is the how.
The implementation gap.
Precisely. It's the difference between having a blueprint for a mansion and actually having the bricks, the mortar, and the masons to build it. We have the blueprints. We are missing the bricks.
So let's talk about those bricks. The World Health Organization has this framework, the 6 building blocks. It's basically the rubric for a functioning system. I'm looking at the list. Service delivery, governance. Where are the biggest cracks in these blocks for us?
Well, let's start with the first one, service delivery. On paper, it means delivering safe, effective care. Simple enough.
Sure.
But in practice, it's much messier. The source cites a study from Ethiopia looking at public hospitals. When they measured those hospitals against these WHO blocks, the performance was only at 60%.
60%, that's a D minus.
It's barely passing. And what that means for a patient is maybe you get to the clinic, but the care isn't person-centered. Maybe you wait for 6 hours. Maybe the right protocols aren't followed.
So it's not enough to just have the doors open.
No. The quality of what happens inside matters. And that quality depends heavily on the second block, which I think is the one we all feel the most. The health workforce.
A human element.
You can't run a system without hands. And we are facing a genuine crisis here. The brain drain is real, of course, but it's also just a basic lack of training capacity. The World Bank data shows most of our countries have fewer than 2.3 health workers per 1,000 people.
2.3 per 1,000. So if I'm in a village of 1,000 people, there are basically 2 people responsible for everyone's health.
Basically. And just imagine if one of them gets sick or moves to the city or emigrates to the UK for a better salary.
The system in that village just collapses.
It's gone. The WHO is forecasting an 11 million worker shortage by 2030, mostly in low-income countries. This is a ticking time bomb.
Then you have the third block, health information systems. This one feels a bit abstract. Is this just about having computers?
It's about having eyes. There's an old saying, if you can't measure it, you can't improve it. Without data, a minister of health is flying blind.
So you're just guessing where the problems are.
Exactly. You're sending drugs to places that might not need them and completely missing the places that do. It's a massive waste of resources we just can't afford to waste. Which, of course, leads to block number 4, medical products.
The supply chain issue?
It is. It's not just do we have the pills, it's are they the right pills? And critically, are they real?
Counterfeit medication.
It is a massive scourge on our markets. A strong system ensures that when a mother buys antibiotics for her child, it's not just chalk powder, and it makes sure the price is standardized so she isn't gouged.
Okay, so we have the service, the people, the data, and the products. But all of this requires fuel, which brings us to the 5th block. And this feels like the elephant in the room. Financing.
This is the root of the tree. If the financing is toxic, the fruit will be toxic.
The numbers in the article are just stark. Current investment in health infrastructure is about $4.5 billion. The region needs $26 billion.
It's not a gap. It's a chasm. We're operating at a tiny fraction of the necessary budget. And that scarcity creates this very dangerous dynamic that Dr. Sandy calls the conflict between real need and felt need.
I wanted to ask you about this. Real need versus felt need. Can you break that down? Because shouldn't the need just be the need?
You would hope so. The real need is what the epidemiology tells you. It's the reality on the ground. Maybe your country has a high rate of maternal mortality or a surge in diabetes. That is what your people are actually dying from.
Okay, that's the real need.
The felt need, in this context, is often what the donor feels is important, the external partner. Maybe there's a global fund that's really excited about tackling one specific tropical disease this year.
Or a foreign government wants to fund a flashy new initiative that looks good in a press release.
Exactly. So because we are desperate for the cash, we contort our national systems to chase the donor's felt need.
And what's the consequence of that?
You get these vertical programs, these silos of excellence. So you might have a world-class HIV program in a district where the basic primary clinic down the road doesn't even have running water. You're basically fixing the roof while the foundation is rotting.
So we're not building a coherent system, we're just building a collection of disconnected projects.
And projects end. That's the danger. Dr. Sani points out that official development assistance, that's ODA to Africa, dropped by 70% between 2021 and 2025.
70%. That is a terrifying drop. That's the funding cliff everyone was warning about.
It's here. And honestly, as painful as it is, it might be the wake-up call we needed. The era of relying on external partners to bankroll our basic survival is over. It has to be domestic. It has to be our money.
So if the donor tap is running dry, how do we fill that bucket? The article does point to some homegrown strategies that are actually working.
This is the hopeful part of the deep dive. This is where we are seeing African nations realizing that the cavalry isn't coming.
So they are building their own cavalry.
Yes. A great example is Nigeria. They have something called the Basic Healthcare Provision Fund, the BHCPF.
Tell me about that.
It's a game changer because it's statutory. The law says at least 1% of the federal government's total revenue must go into this health fund. It's not optional.
So before they spend on anything else, 1% is locked in for health.
Correct. It creates a predictable, sustainable pipeline of domestic cash. It anchors health financing in our own national wealth, not in foreign aid.
That's huge. And then you look at Ghana. They've been tackling that fragmentation issue we talked about, the chaos of too many donors, with something called a sector-wide approach, or SWAP.
SWAP is brilliant. It basically says, we have one national health plan. If you want to help us, you put your money into this basket.
So the government takes the driver's seat.
Completely. It aligns all donor support under one umbrella. No more duplication. You don't get 3 NGOs building clinics in the same village while the next village has none. It forces efficiency. Tanzania is doing something similar. It's about reclaiming the roadmap.
It sounds like a declaration of independence in a way. This is our house. These are our blueprints.
It is. It's moving from being a beneficiary to being a leader.
But even with the money and the plan, we still circle back to the workforce. We can't just snap our fingers and create doctors. How are we addressing the immediate shortage of hands?
You're right. We can't wait 10 years. The solution, and we're seeing this across the continent, is decentralized delivery. We have to stop obsessing over the big, shiny city hospitals.
The ivory towers.
Exactly. The real battle is won in the community. The strategy is to train and empower community health workers, midwives, and nurses who live in the villages they serve.
This plays to our strengths, doesn't it? Our community ties are incredibly strong.
They are. If a community health worker can treat a child's fever right there in the village, that patient may never need the expensive city hospital. It saves money, it saves lives, and it builds trust. It turns the health system into something that lives with the people.
But the source material mentions new challenges are already on the horizon. It talks about needing climate-resilient and migrant-sensitive systems.
This is critical. We cannot build a static system for a dynamic world. Climate change is altering the map of disease.
How's?
Mosquitoes are moving to higher altitudes as temperatures rise, so malaria is appearing in new places. Droughts cause malnutrition. Floods bring cholera. A rigid health system will break under that pressure.
And the migration piece.
People move. For work, fleeing conflict, whatever it is. If your health record is a paper file in a village you left 3 years ago, the system has failed you. We need portable digital record systems that follow the African citizen wherever they go.
It feels like we are at a massive turning point. We started this with a $2.4 trillion loss, a staggering wound. We walked through the WHO building blocks, the trap of donor dependency, and now we're seeing the path forward.
It's a path of ownership. It's painful, yes. When that aid drops 70%, it hurts. But it is the growing pain of maturity.
It's Nigeria locking in that 1%. It's Ghana unifying the plan. It's realizing the solution isn't always a new MRI machine, but maybe a well-supported community worker with a tablet.
And here's the so what for everyone listening. A strong health system is the bedrock of the social contract. When a government provides reliable health care, it builds legitimacy. It says to its citizens, we value your life.
And economically, you cannot build the Africa we all want, the Africa of innovation, of growth on the backs of a sick population.
Impossible. Health is wealth. That is not a cliche. It is macroeconomics. Yeah. This is how we unlock our continent's demographic dividend.
I want to close with a quote from Dr. Seni that really stayed with me. He said, "Africa has no shortage of policies or ambition. When we lead our systems, we unlock our solution."
It's a call to action. We have the intelligence. We have the ambition. Now we just need the discipline to fund it and the courage to implement it ourselves.
And that leads me to a final thought for you to take away. We've talked a lot about healthcare today, but zoom out. If African nations succeed in fully funding our own systems, if we truly break that reliance on external donors for our most basic survival, how might that fundamentally shift the power dynamic in global geopolitics?
That is the ultimate question. If you pay for your own survival, you don't have to bow to anyone. Financial independence in health. It's the first step toward true geopolitical independence.
It changes who sits at the head of the table.
Please subscribe.
Thank you for joining us on this deep dive.
Always a pleasure.
We'll catch you on the next one.
Please subscribe.